This is our recorded lecture for the urinary system, chapter 16, urinary system and venipuncture. We are scheduled to do a venipuncture lab coming up. I think that's the first week of June, so I'll be talking to you guys about that, and we'll get the phlebotomy waivers signed for those of you that wish to volunteer for that laboratory. We do need some volunteers if we can. It's not mandatory, but of course it's always a richer learning experience when you get to attempt a venipuncture on a real live person. So those of you who have nice big juicy veins that are easy to stick, I would strongly encourage you to volunteer for the venipuncture lab. This chapter focuses on the urinary system, and usually it's contrast assisted, iodine contrast assisted procedures that we're talking about here for the urinary system. So over and above just a regular KUB, we're going to inject contrast into the urinary system or get the contrast into. There's a couple different ways you can go about it, but I'll explain that as we go through. We're going to start out with the anatomy of the urinary system. We're going to talk about positioning parameters for exams. We're going to talk about contrast media. We're going to talk about type, dosage, and route of administration. It varies according to procedure and specifically which way you're going, whether it's an intravenous injection, which is called an antegrade contrast administration, or if you catheterize the patient and get the contrast into the bladder, or selectively cannulate a ureter and get the contrast up. That's retrograde contrast administrations, and I'll explain the difference between those two terms coming up. We'll talk about dosage and also the strength variance of contrast for the bladder versus for what's called an IBU. So we do two different types of contrast depending upon if it's a cystogram or an IBU. And then we'll talk about what contrast media is going to allow us to visualize that we wouldn't normally visualize. And we've got representative radiographs for that in the upcoming lecture. So we start off anatomy of the urinary system. The urinary system consists of two kidneys. Hang on just a second. Sorry guys, interrupted by a phone call. Hang on just a second. Sorry, I think I was saying two kidneys, and then coming off the kidneys, those are ureters, left and right. Now this is all normal anatomy. Patients can live with one kidney if one of the kidneys gets diseased or damaged, or if they donate it. A human being can survive with just one kidney, but you have two. Most people have two. To start with, and then the ureters are the ducts that take the excretion of the kidney and transport it to the urinary bladder, and that is a peristaltic motion. The ureters are wrapped with a smooth muscle layer, and so is the bladder for that matter. And then the bladder empties into the urethra. So make sure you keep those straight. The ureters connect the kidneys to the bladder. The urethra is the exit point for the system. It's how you void the bladder. We call that peeing in layman's terms. So those are the major components. The kidneys are retroperitoneal. They're not in the peritoneal cavity. They're behind the peritoneal cavity, at the posterior abdominal wall. The superior aspect of the kidney is more posterior than the inferior aspect of the kidney. And they don't really face forward and have the renal pelvis, the connection to the ureters, exactly on the medial border. They're kind of in an oblique setting, 30 to 45 degrees off of the mid-sagittal plane is the arrangement of the kidney in the abdomen. So not really part of the urinary system, the adrenal glands. sit on top of the kidneys. This is where you make your adrenaline, also called epinephrine, which means hormone pertaining to beyond the kidney. They add renal glands. Add means above the renal. So the gland is both names for the gland is above the kidney. Right, so this demonstrates, the CT slice demonstrates the orientation of the kidney. It really doesn't, the renal pelvis really doesn't face medially, it faces medial anteriorly. As you can see there, the black arrows indicate those white horseshoes, that's the actual kidney itself. And then the middle of the horseshoe is the collecting duct network, the calyxes. And then the ureter is actually coming off of the opening of the horseshoe there. Okay. And then you get your major veins and arteries coming out. Your renal vein, your renal artery also enters through the opening of the horseshoe. That's called the hilar region of the kidney. So this CT slice is just to show you the orientation of the kidney. It's not in a true AP until you're in like a 30-degree oblique. Okay. All right, so as far as breaking down the internal components of the kidney, this is a nice macro diagram. This is like a cross-sectional slice of the kidney. If you slice the kidney vertically, this is what you would see. You see the entire thing is contained within a renal capsule. That's just a membrane coating. And then the individual components are called renal pyramids. Okay? Renal pyramids are part of the renal medulla. Okay, but the pyramids are like bundles of nephrons. So nephrons start in the cortex, but the duct part of the nephrons is in the renal medulla. Okay, and then as those collecting ducts bundle together and merge, they eventually form the minor calyxes, and then the minor calyxes join together to form major calyxes. The major calyxes join together to form the renal pelvis. Okay. Yeah, that's about the major parts. The hilar region is the medial aspect of the kidney, even though the kidney's at an oblique. The hilar region is where the renal pelvis exits, but also where the renal vein and artery exit the kidney. So it's that entire entranceway for the major blood vessels and the exit point for the renal pelvis that tapers to the ureter. Okay, so that's an upcoming quiz question. There will be an arrow indicator, and it either points to the region of the hilum or it points just to the renal pelvis, but both of those are multiple choice questions or multiple choice choices in those questions. And so I see a lot of students label an indicator for the renal pelvis as the hilum, when the hilum is actually including that entire area of the renal artery, renal vein takeoff, and also the renal pelvis takeoff from the medial border of the kidney. It's a zone, it's a region, very much like the hilum of the lungs is a region. Okay. All right, so the functional component, the parenchymal tissue of the kidney, just like the lung has parenchymal tissue, that's the alveoli, the functional or parenchymal tissue of the kidney is the nephron. Every kidney has a roughly 1 million nephrons. The nephrons have a corpuscle that's located in the cortex, and then they have the tubule, which is composed of a couple parts. Okay, the corpuscle is the glomerular capsule, also called Bowman's capsule, and the network of capillaries called the glomerulus. That's where the excretion of the waste product starts, is from the glomerulus. So I apologize for the font being so small. This is straight from your textbook, so you can look this up in your textbook so you can see these. But basically, it starts with an afferent arteriole brings blood in from the renal artery, okay? And then it wildly distributes into like a ball of capillaries. That's the glomerulus, okay? So the spheroid of capillaries, the pressure from the arteriole is fairly big, and then you diffuse it into several capillary channels or pathways, and then you make the lumen extremely small, extremely rapidly. And what happens is most of the plasma, well, I wouldn't say most, some of the blood plasma actually penetrates through the capillary web wall, the capillary ball wall, the glomerulus, the walls of those vessels in the glomerulus. The plasma actually just passes through the membrane wall and out into Bowman's capsule. Now the blood plasma is carrying waste products at this moment, and it's also carrying pH stabilizers, but mostly water. So blood plasma is mostly water. Hopefully, if you're well hydrated, it's mostly water. But the urea, the waste products from the cells, are dissolved into the plasma. And so the first thing to do is to extract the waste-laden plasma from the blood at Bowman's capsule, and then that waste-laden plasma starts passing through. Now, you don't call it plasma when it's outside of the bloodstream. You start to call it urea, named after the most prevalent waste product that's dissolved into it. It starts to enter the proximal convoluted tubule, and that's where a lot of the plasma is reabsorbed. A lot of the valuable nutrients that were, there's specialized cells in there that can identify valuable nutritious stuff that's in like your vitamins, your minerals, your amino acids, some lipid branch molecules, your glucose. Those type of things are reabsorbed immediately and deposited back into the bloodstream. Okay, that's at the proximal convoluted tubule. Okay, then at Henle's loop, the urea now becomes concentrated as the water and the nutrients are drawn off of it. Only thing is left is just enough water to keep it liquid, and the waste products themselves, the urea itself. Okay. That passes through Henle's loop. Okay. All right, so then it descends through Henle's loop. Yes, I did step away. I'm sorry. The urea at this point is like the majority of the content of this stuff. There's very little water content left, just enough to keep it liquid, keep everything dissolved. But it does not resemble blood plasma anymore. Okay, passes through Henle's loop, and then it enters the distal convoluted tubule. The distal convoluted tubule is the last place where water can be added back to the urea, and then once it leaves the nephron at the distal convoluted tubule and enters the collecting duct, it is no longer urea, it's urine at that point. So all the nutrients have been reabsorbed, and then it's been water balanced so that it will hopefully remain liquid all the way to the urinary bladder. Patients who get dehydrated or have kidney disease have trouble with keeping or forming kidney stones. They have trouble with adding enough water back to the urine such that it stays liquid and you actually get urea salts, nitrogen salts deposit out of solution because the solution's too concentrated, and that's where kidney stones start to form, is when the nitrogen salts start precipitating out of solution, because there's not enough water to keep them dissolved and the concentration gets too high. All right, so your ureter is 10 to 12 inches long. It enters the posterior lateral surface of the bladder, okay? And its entire job is to convey urine from the renal pelvis to the bladder via peristaltic contractions. So the nephrons filter the blood by excreting a lot of the plasma in the Bowman's capsule, and then nutrients, sugars, dissolved minerals that are useful, and basically any substance up to and including water that is useful and nutritious to the body. The kidney will reabsorb that and put that back into the blood, leaving just the waste product molecules and hopefully enough water to keep them dissolved. Okay. Water can be added back to the urine if the urine gets too concentrated, so long as the patient is not aggressively dehydrated. Okay. Once the ureters pass the urine down to the pelvis, they enter the urinary bladder, which is just a membranous sac. It's got some nerve fibers in the wall of the bladder, and the entire thing is surrounded by smooth muscle, and that's what causes bladder contractions, which gives you the sensation that you have to go to the bathroom. Okay, that has to be a trained response, as everyone knows, and some people don't train to that response. So there are the ureteral openings, and the urethra exit point form a rough triangular shaped region called the trigone. Okay, and the bladder wall in the upper and lateral borders of the bladder, that's where you'll find the pressure nerve fibers, and as the bladder fills, it starts to stretch, and as the wall feels that stretch, it compresses those pressure sensitive nerve fibers, and then you get the sensation like your bladder is full and you need to make a quick jog to the restroom so that you can empty your bladder. So that sensation is caused by a full bladder, by the bladder expanding and stretching. So it is slightly flexible. It can increase in volume, but that usually triggers a nerve impulse. As the bladder gets to full, it triggers an impulse where it's basically like, ooh, I need to pee, that type of thing. So the weak spot of the urinary system is definitely the ureters, because the ducts are so small. The urethra is another weak spot, but as far as kidney stones go, once the kidney stones are to the urinary bladder, they're considered past, because the ureter is the tiniest diameter tube. The urethra is a larger diameter, and most small stones, if they can get all the way to the ureter, they have no trouble exiting the bladder. So yeah, it's the ureter where the stones get stuck typically. Okay, so our urethra is the exit point of the bladder. It conveys the urine out of the body. That is actually the muscles that control the opening to the urethra are actually contained in the abdominal pelvic floor. And so that is a skeletal muscle. That's something you can manipulate. You can actually contract it if a bathroom's not available, and hold your urine until an appropriate time. And I mean, eventually it does get so full that the bladder just starts spasming out of control, and then you just lose that that urine, eventually you are going to pee yourself. So don't practice holding it. But your lower abdominal, your pelvic floor abdominal muscle can kink off the urethra, and you can hold your urine for a short amount of time. It differs in lengths in males and females. And then also the male urethra, not a part of the urinary system. Part of the male reproductive system is the prostate gland, which is a donut-shaped gland, poor design, around the urethra, and 1 out of 3 males in middle age and old age will experience prostate hypertrophy, where the donut swells shut, okay, and clamps off the urethra, and then there's difficulty urinating, but always feeling like you have to pee. And that's because urethra is being clamped shut by a hypertrophic prostate gland. There is a surgery that can fix that. That is not prostate cancer. Prostate cancer is a whole separate issue. Prostate hypertrophy is 33% probability for male patients, male members of humanity, 33% of the time. But in your 50s and 60s, 1 out of every 3 males has prostate hypertrophy. Right, so it's a small glandular body that's part of the male reproductive system. Okay, it's often described in the urinary system, and it contributes to a pathology of the urinary system that I just described. Okay. Males in middle age will have to have a prostate examination annually to check for hypertrophy, because there are medications and supplements that can be taken to reduce the extent of prostate hypertrophy. And so if you can take a pill to avoid a surgery, I would recommend taking the pill to avoid the surgery. All right, let's talk about contrast media. Okay. Contrast studies for the urinary system are both conducted in X-ray and CT. CT has taken over a lot of the examinations that we're going to talk about. It's very rare to do an IVU anymore because CT can diagnose all the pathologies that an IVU can diagnose, but it can do it with less superimposition, so it's actually more definitive to get a CT scan of the urinary system rather than a plain X-ray IVU contrast-enhanced urinary system study. I'm still required to teach you about the IVU. It's still eligible content for the registry exam. All right, so I mentioned there's a couple different ways to introduce contrast to the urinary system. The urinary system functions as the waste product filter for the bloodstream. Everything that's considered a waste product except for carbon dioxide exits through the kidneys. So long as you have viable kidneys, it exits through the kidneys. And that describes the antegrade technique. So if you give intravenous injection of iodine contrast, the kidney is going to excrete that within and pull that out of the bloodstream because it'll recognize it as a non-nutrient. Okay, the iodine that is bound organically in the contrast media is not dissolvable. It can't be taken up by the thyroid gland, and so since it's not available to the thyroid gland, the kidney identifies that compound as waste and excretes it, and so intravenous contrast eventually ends up in the kidneys. And that's the antegrade. Antegrade means introducing the contrast along the normal physiological flow of the system. So an antegrade GI study would be an upper GI. You feed the patient barium in through their mouth because that's where they take food is in through their mouth. And then it goes from the mouth to the esophagus, to the stomach, to the small bowel. and you can take pictures of the barium, but that's the same pathway of the food for the GI system. You put something in your mouth, you chew on it, you swallow it, it goes down your esophagus to your stomach, and then it goes, after the stomach works on it a little bit, it exits to the small bowel. So because the roots are the same, that's called antegrade fill. Okay? A retrograde fill is introducing contrast against the normal physiological flow. Okay? For a GI study, all barium enemas are retrograde filling techniques. For urinary studies, catheterization of the urinary bladder and filling the bladder or selectively cannulating the ureter from inside the bladder and then injecting contrast into the ureter via a catheter. Those are retrograde filling techniques. Okay? And so that's the two different ways we can introduce contrast to the urinary system. Okay? Now the contrast media we inject or we push antegrade IV is not the same contrast as we use retrograde for like a cystogram or a cystourethrogram. Okay? So the bladder needs a larger amount of contrast, and so you need to reduce the concentration of the contrast that you do fill it with because it's such a large volume. There is some absorption across the bladder membrane, and you don't want it highly concentrated because it could trigger an allergic reaction. Okay? So lower concentrations because you're using higher volume to fill the bladder. Typically a cystogram bladder study under fluoro is going to use just under 1,000 milliliters, just under a liter. Okay, normally those bottles are 750 milliliter or 800 milliliter bottles, and it usually takes like 3/4 of that bottle. I forget what the brand name of the common contrast for a cystogram is, but it's in a bottle, and it's usually an 750 milliliter capacity or an 800 milliliter capacity. About the size of a wine bottle, basically. All right. Higher concentrations are used in excretory urography. Excretory in this situation is the same as antegrade filling, okay? Because the kidneys excrete the urine into the duct network via the nephrons. So an excretory urography necessarily means that the contrast is passing through the nephrons of the kidney. Now, we also want to note, they always tell this, even though non-ionic contrast media has basically been permanently removed from ionic contrast media has been nearly completely removed from the marketplace. Non-ionic media is less likely to dissociate into ions when it's in the bloodstream, and so therefore less likely to produce an allergic reaction. Nowadays we used organically bound iodines rather than ionic iodine salts dissolved in water, because we recognized that the ionization of the iodine salts was contributing to or catalyzing anaphylaxis, mild and moderate anaphylaxis reactions. Okay, so if you have two products on the marketplace and they do the same job, but one is more risky than the other, which one is going to eventually leave the marketplace? Well, yeah, why would you buy a product with risk when there is a competitive product with less risk? You wouldn't buy the product with risk, and that's why we don't see ionic media in the marketplace anymore. It's all non-ionic media. We're still going to ask about it on the credentialing exam, but you're never going to encounter ionic contrast media anymore. Okay. So it's a good time to, as we're talking about contrast, it's a good time to review adverse reactions to contrast media. Okay. Most of the time, patients have mild reactions or no reaction at all. Okay, it's less than, I don't know exact numbers. I did it when I was in X-ray school. It's less than 10% of the population is allergic to iodine. Okay, you're going to do a history and physical pre-screen with any contrast study that injects iodine, both X-ray and CT. And one of the questions you will definitely ask is, does the patient know if they're allergic to the X-ray dye, to the iodine injectable contrast? Give me a second. All right, so what is a mild reaction? A mild reaction is going to be like a funny metal taste in the mouth, like someone had put a penny in their mouth. Don't do that. Those things they carry disease. Money is always dirty. Or they get a flushing sensation running from their torso down through their legs. This is very common in CT with a power injector. A lot of patients report it feels like they are peeing their pants or they're wetting themselves. Okay? So it's a warm sensation that rolls through the body as the iodine is injected. Okay? A warm flush feeling. Those are both mild reactions. Okay? It's important for you to know what is the critical sign that definitely tells you're in a moderate stage of reaction. And that critical sign that says you're at moderate stage is full body hives. When hives are systemic, after contrast injection, you're in moderate. Will it taper off? See, mild reactions just kind of fade away. But moderate reactions, we have to assume that they're about to go severe. They're about to go full anaphylaxis. So if you see full body hives, it's a registry question. First, stop injecting, okay? And then second, call for rapid response. Get your crash cart, get your patient into recovery position, all right? Try to assess their airway, try to, comfort them, calm them, keep them conscious if you can. If you have an IV started, make sure that IV remains patent because that's a useful site for injection of epinephrine and or IV Benadryl to arrest the allergic reaction, to stop the allergic reaction. Okay? Clinical history will be taken anytime and the radiologist has to review that clinical history. In the event the patient is in fact allergic to iodine, it's the radiologist's determination as to whether or not you proceed with the examination. Typically in an outpatient setting, we'll know that information. The patient reports that they're allergic to iodine, and we have them pre-medicate with Benadryl the morning of the procedure so that they already have antihistamines in their system to tamp down any allergic reactions if they are proceeding. Okay? A lot of times it's the recommendation of the radiologist to order an alternate procedure rather than one that involves injection of iodine contrast when the patient is allergic. Okay. When you're injecting iodine and you're monitoring for allergic reaction, remember that it's not just 5 minutes. It's now the high probability is within the first 5 minutes, but an allergic reaction can happen up to 1 hour later, half a day later, things like so. Always watch your patient after you've injected contrast until it's time to hand them off to someone else, and then warn them about the possibility of allergic reaction. Okay? You should know where the crash cart is if you're injecting iodine. We usually keep it in CT because they inject the most iodine of any modality. You should know how to call for rapid response in the event of an anaphylactic reaction to contrast media. Okay. Now, for an outpatient contrast study, both CT and X-ray, you are going to want them to have a bowel preparation if they're an adult patient, because Stool and bowel gas can obscure, especially on X-ray, they can obscure views of the kidneys, the calyxes, the renal pelvis, and the ureters, and they can also obscure adequate visualization of a stone. With a CT scan, they don't really superimpose because we're taking the images in slices and we get rid of any superimposition. So it's less of a factor with a CT scan, but you need a good preparation to clear the bowel of superimposing structures, excessive gas and or fecal material, so that you can get a good diagnostic view of the kidney and the urinary system in total. Okay. Infants and children's, we don't really do a bowel preparation, but remember the bowel is a little bit smaller, doesn't get in the way as much. And so your infants and children, the children are probably just going to be held NPO before the study, and just we get the best that we get. It's only going to be your adults that are going to have to take an enema preparation kit to clear themselves out, unless it's contraindicated for dehydration or some such thing, which makes it difficult to do a urinary system study too. Okay. You won't do bowel preparation on all of your IVUs. It's just, it makes for a better diagnostic study if we do. Okay. So the patient that is going to have some kind of urinary system study done, they need to be well hydrated. Patients with diabetes, multiple myeloma, or high uric acid levels, the hydration is critical because all of those conditions could, coupled with dehydration, could create a condition called contrast-induced renal failure. Okay. Basically, remember how I said the glomerulus, the network of capillaries, basically sheds the blood plasma and all the dissolved waste inside it? Well, concentrated iodine contrast, organically bound, has a viscosity of maple syrup. And so if the patient's not well hydrated, the urine is going to be concentrated, and you can actually just gum up the individual nephrons with very sticky iodine contrast that is also very thick. And so then the kidney basically shuts down. If urine's not flowing all the way through it, it causes renal failure. Okay. Once you have renal failure, typically the tissue damage is extensive and you don't get the kidney back after it fails. Okay. So we're going to do a glomerular filtration rate lab. It's a blood draw, and then it takes into account several other factors in a calculation of a filtration rate. Okay, so it takes direct measurements from the blood, but it also factors in patient's age, their sex, what race they are, and just has mathematical multipliers or ratios to adjust the measured number into a GFR measurement. Okay, the laboratory technicians have a computer software that calculates that automatically. We went to GFR while I was a tech. Okay, before GFR, it was BUN and creatinine level, which is a fair estimate of kidney function. BUN stands for blood urea nitrates, and so it literally measures the concentration of urea in your blood. And then creatinine, it's an organic molecule. It's a waste product of the muscle, but that indicates overall the creatinine concentration basically indicates overall hydration levels. If creatinine is high, then the patient's considered dehydrated. If the creatinine is low to normal, then the patient is adequately hydrated. Okay? So we used to use BUN creatinine. You might hear the text talk about BUN and creatinine. The new medical standard is for injection of iodine contrast is GFR, glomerular filtration rate. Now I want to tell you the normal value for that before I leave this slide. Hang on just a second. Yeah, so in your textbook, this is volume 2, page 302, first column. National Kidney Foundation considers normal GFR range to be 90 to 120 milliliters per minute, and a value of 90 milliliters per minute or less as an indicator of renal dysfunction. So that's your GFR rate. Okay. They still cite creatinine level in the textbook as well. The normal creatinine level is 0.5 to 1.2 milligrams per 100 milliliters. That's a tenth of a, so it's a deciliter. It's a tenth of a liter. So 0.5 to 1.2 milligrams per 100 milliliters. That's your normal creatinine range. But the GFR is the new standard for determining whether it's safe to inject contrast. GFR is supposed to be 90 to 120. One more time. That will be a quiz question. That will definitely be a registry question. All right, so preparation for retrograde urography, that is going up through the bladder. That takes a urologist to do. That's a specialized examination that they do in the urology suite in the OR. But the patient should be well hydrated either by IV or if they're an outpatient, same-day surgery for kidney stone removal or some such thing, or placing a stent or whatever. They should be drinking 4 or 5 cups of water a couple hours before the exam or before the case, before the surgical procedure, excuse me. It is technically still a surgical procedure. Okay. Lower urinary tract, like a cystogram, we don't need hydration if we're only filling the bladder with contrast. It's the nephrons that suffer, and you can cause renal failure if the nephrons are inadequately hydrated as you're trying to pass contrast through them. You can shut down a patient's kidney, so it's a high risk type thing if you're not monitoring for the patient's hydration level. Okay. So a standard radiographic room for excretory urography, you can do the IVU in a regular conventional radiographic room. You don't need a fluoroscope for an IVU. A VCUG, you do need a fluoroscope for that. And then you need a cystographic suite up in the OR for retrograde urography, okay? Because that requires a cystoscope, which is run by the urologist. Only the urologist has been trained with the specialized skill set of cannulating the ureter from inside the bladder. And that's a procedure. We don't really see that one anymore. They don't invite us to the room anymore, at least not here in Tennessee. State of Tennessee says that any surgeon or any medical doctor is a qualified fluoroscope operator, and so the urologist can run their own fluoroscopes. Okay? And so that's why they don't invite X-ray up very much. Right? If we're doing nephrourography or nephrotomography, we are going to need a tomographic unit. Okay. Some of the newer digital machines actually have volume rendering slices. They can do a tomographic sweep with some of the newer digital systems. It's an extra software package. We used to do kidney tomography as part of IVU exams. But we don't do IVU exams, and we don't do renal tomography anymore because we have CT scanners now, and they can do it better than we ever could with a plain room. Okay. So if we are doing an IVU or any kind of urinary system study, we want our radiopaque markers, we want our body position markers like upright or supine, and then we also want time interval markers because the radiologist is going to use the time post-injection label to determine whether the kidney is running on time, that is it excreting at a normal rate, or is it slowed, which leads to a pathology called hydronephrosis. Okay, slowed kidneys are often a secondary effect of having a kidney stone, and that hydronephrosis is also a secondary effect of a kidney stone. And so time markers for plain X-ray exposures are necessary so the radiologist can gauge whether or not the kidney is functioning appropriately. Okay. Sufficient number and proper size image receptors, that's not a consideration with digital radiography anymore. That's more a bullet point for screen film radiography. Of course, if you're using CR plates, you might want to have 3 or 4 14x17s available. The emergency cart doesn't need to be in the room, but it does need to be readily available. Check to make sure it's stocked. That's usually done by the risk assessment nurses, or a member of the rapid response team comes around to make sure that every crash cart is stocked every morning at the beginning of every shift. So you don't need to make an individual check of that crash cart. Knowing where it is, usually CT, sometimes the angiographic suite, is pretty important when you're injecting iodine contrast. Okay, CT injects the most, so it makes sense to leave the crash cart outside of CT. Venipuncture supplies for an IVU, you're going to need a butterfly needle. You can use an angiojet needle if necessary. You're probably going to want an angiojet needle if you're using a power injector in CT. But for hand syringe injection of contrast, a butterfly needle is sufficient. Okay. All right, so our procedure, we don't want to forget about image quality. We're still going to be dealing with peristaltic motion, even though the patient has had a preparation. We're going to want to take a scout film because the adult patient is going to be prepped for this, so we want to make sure the prep was effective. But we also want a non-contrast comparison view to all the other images we take later in the study. Okay. Motion control, the kidneys do oscillate when the patient is breathing. They will move up and down on breaths in and breaths. So as the diaphragm moves, so does the kidneys move. And so you want the patient to be holding their breath during an exposure. Holding their breath on expiration allows the abdomen to spread out and we get less superimposition, and that holds true still for urinary system studies. Ureteral compression, you can actually place a compression band just above the pelvis, okay? Maybe starting at the level of the ASIS, and an anterior compression band will kink off with enough pressure. The ureters will kink off, and so you can arrest the peristaltic motion of the contrast and fill the kidneys up with lots of contrast early in the study, and also have patent ureters all the way down to the compression band, and just makes for a nicer radiograph of the upper urinary system. The ureteral compression will be the radiologist's preference. I've never done an IVU with ureteral compression, but it may be warranted. Okay. Respiration, again, expiration and hold is going to be the best. as far as controlling breath motion and spreading overlapping tissues out further. The abdominal area increases in volume when you blow your breath out, and so tissues that are stacked on top of each other necessarily spread out more, and then we decrease superimposition. Okay? The preliminary exam, that is the scout film. You want to take a scout film for comparison to later films that you take, or later images rather that you take, where the contrast has entered the system. If we find what looks like evidence of a stone in a contrast image, one of the first things the radiologist does is mark that location and compare it to the scout film and see if he can see a calcified opacity there at that location, and then that's definitive for a kidney stone. Okay, there is some calcium content to kidney stones, and they do show up fairly well on an x-ray. They're obscured by the iodine contrast. They're actually, because the iodine absorbs all the x-ray, and so it's harder to see a stone once you've injected the contrast. But if you have a comparison scout image of the tissue before you've injected contrast, well, then the stone will pop out. Okay. And then, of course, radiation protection for the urinary system. It is about impossible. Your male patients can be shielded with a contact shield. Your female patients cannot be shielded. The ureters pass right in back of the ovaries. Okay. And so attempting to shield a female patient for a urinary system study is going to make the study non-diagnostic because you're obscuring pertinent anatomy. Remember the AAPM, the American Association of Physicists in Medicine, did release a paper. I think it was either 2013 or 2012. That paper stated that they didn't say shielding was unnecessary. They said shielding didn't make any difference in abdominal pelvic studies. They didn't say anything about shielding for hand x-rays. They didn't say anything about shielding for any extremity x-rays. They didn't say anything about shielding for chest x-rays. They said for abdominal pelvic studies, shielding is basically a wash. It doesn't have an impact on reproductive organ dose. Okay, the patients, if the shield is covering the gonads, but you're exposing the pelvis to radiation, like in the case of a male, internal scatter radiation is going to still supply dose to that patient's gonads. And that dose is in the same magnitude as if the patient wasn't wearing a shield. Okay? And so there's no way to effectively shield for abdominal pelvic studies. Okay? Motion control. Immobilization not recommended because of interference with fluid flow through the ureters and distortion of canals. Okay? So that means you don't want to tie the patient down necessarily. Tying the patient down with a strap across the abdomen and immobilizing like a posy vest or the equivalent of a posy vest, that will kink off the patient's ureters partially, and then it will distort the physiology and also distort the normal diameter of the patent ureter. Okay, it'll have any compression applied if the radiologist is unaware of it will give a false positive for stenosis in a ureter. Okay. So how do we control motion? Well, peristalsis is automatic. We can't really control that. We can only control exposure time. And so by having a really small exposure time, you arrest peristalsis and don't allow it to move, because you remember the velocity formula involves time in the denominator. So if time's not allowed to pass, you can't really have a velocity. Nothing moves if time stands still. Okay. unless you're Quicksilver. That was the coolest scene in the X-Men movies. Okay. Patient cooperation. Okay. The patient has to agree to exhale and hold. Okay. If the patient forgets or doesn't hear you and breathes through the exposure, you're definitely going to have blurred kidneys and ureters because the kidneys oscillate in time with the diaphragm. So if the diaphragm's going up and down during the exposure because the patient's still breathing, the kidneys are going to be oscillating up and down, and then you're going to get a motion artifact. Okay, and you'll have to re-expose. Okay. Important to inform the patient of sensations caused by contrast injection. So you want to tell them about the funny taste in their mouth. You want to tell them about the warm flush feeling. You also want to tell them if they start to feel itchy or extremely hot, they want to report that to you immediately. If they feel like a sense of panic, you'll want them to report that to you immediately. If they feel like they're struggling to breathe, like their throat is closing, it's going to be hard for them to communicate that, but they need to signal you. Okay. All right. End of expiration. Again, that spreads out the overlapping tissues of the abdomen and reduces superimposition. Okay. Kidney excursion during respiration is possible to differentiate kidneys from other shadows by making exposure on different phases of respiration. Okay. And so apparently the internal abdominal pressure determines how much the kidneys excurge during respiration. Okay. Image should be marked if exposed on phase of respiration other than expiration. So if you tell the patient to take in a deep breath and hold it, you should mark exposed the image, make a note on the image that it was inspiration, that the image was taken on. Here's your ureteral compression band. This is applied just to kink off the ureters temporarily so that we can fill the renal pelvises and the renal calyxes with contrast and get a really good nephrogram, if you will. Okay. Center your compression band over the level of the ASIS. So I do remember it was something to do with ASIS. Compression band has to be snug, tight enough that it's actually compressing the stomach, but not so tight that the patient is unnecessarily uncomfortable. Mildly uncomfortable, yes. Uncomfortable to the point that it's pain, they would say it's painful, no. Okay. So you do want a scout film. The scout film marks extrarenal lesions. Okay. It also determines whether or not the prep was done adequately, and it gives you a non-contrast view of the entire urinary system, the kidneys, the shape of the kidneys, opaque calculi, those are stones if present. Okay? So the radiologist, if they see evidence of stone, once contrast is injected, they will refer back to the scout image to actually look for the opaque calculi, the kidney stone itself. Okay. The contrast image won't show you the kidney stone because the kidney stone will be buried in iodine contrast and you won't see it. Radiation protection, gonadal shield used if it doesn't interfere with the exam objective. For female patients, it's definitely going to interfere. For male patients, you can use a contact shield, but the AAPM says it's not necessary. Okay, close collimation. Okay, collimate to the urinary system, so that includes the bladder. So the bottom of the image receptor has to be probably an inch below the pubic symphysis, and then orient portrait style. You never do IVU's landscape style, because the kidneys, the ureter, and the bladder are all really close to the midline. You don't need the lateral aspects of the abdomen. You can collimate in from side to side. I would limit it to, let's see, side to side in portrait orientation is 14. The most I would collimate in is like 12 or 10, depending upon habitus. But I know the kidneys are closer to the center. They're not at the lateral margin of the abdominal border. They're at the center. Okay, just off the center to the left and just off the center to the right. So I can trim, I don't need the entire abdomen, I can trim my collimation inside to side for these urinary system studies. Okay. So the various procedures, the IVU is the one I've been talking about most. That's the one that's gone away mostly because of CT scan, in addition to nephrotomography, which is sweeping the X-ray tube through an arc and creating slices at the fulcrum of the arc. The X-ray tube sweeps one way and the image receptor sweeps the other way, and there's a pivot point for that sweep, and hopefully that pivot point is right in the center of the kidney. Okay? And so what it does is it blurs the anatomy above and below that fulcrum point, and you can see the anatomy at that fulcrum point better. That's a nephrotomogram. Nephrotomograms are definitely inferior to CT slices. Okay? A nephrostogram, sometimes also done in surgery, possibly done in a fluoroscopic suite with the guidance of a radiologist if they have an indwelling nephrostomy catheter that you can inject through. But typically the nephrostogram is part of a surgical procedure for percutaneous nephrolithotomy, which is cutting a hole down into the kidney and inserting an ultrasound wand to break up what's called a staghorn kidney stone. It's a kidney stone that has grown so much it fills the entire renal pelvis and most of the major calyxes, the entire calyx network. So it's not going to be passed. Okay, it's about the size of if you make a fist, a loose fist, a staghorn kidney stone is about the size of the inside of your fist, if your fist is loose. Okay, so it's pretty big around. About, if a cigar was like shorter and fatter, that's what a staghorn kidney stone would be. Okay, and they call it a staghorn because it looks like a moose antler when you take an X-ray of it, non-contrast, because it's made of calcium and urea salts, and it fills the calyx network, and so it branches out into the individual major calyxes, and that looks like a moose antler. So that's why they call it a staghorn kidney stone. Again, that's your nephrostogram that you're going to encounter those in, and usually it's in the surgical theater. Retrograde urography is always in the surgical theater. It's always done by a urologist. He's putting a scope into the bladder, a cystoscope, via the urethra, and then he's inserting a wire into each ureter or into one ureter, depending upon if it's a bilateral or unilateral procedure. And then he's going to put a catheter up on that wire and inject contrast into the ureter to try to visualize the ureter from the bottom side, from that retrograde approach. Okay, you definitely need to be in surgical theater, and you need a urologist to selectively cannulate a ureter. It's a specialized skill. A cystogram, you're going to need to go to a fluoroscopy suite for a cystogram. Usually cystograms are VCUGs. Not always. It can be just a conventional cystogram. Okay, cystogram means that the cyst is the bladder. I remember cysto means sac. So it's a radiograph of the bladder and the bladder only. This is done for incontinence primarily, inability to hold your urine. Okay. Cystourethography, second cousin to cystography. both males and females. You can do a cystourethrogram to evaluate hypertrophic prostate. Usually they're going to do that with a palpation exam for the males. And remember, females don't have prostates, so we don't need to do a prostate exam on them, even though we definitely had one employee show up for the free prostate screening they give here at NGH. She was told that we probably didn't need to check her prostate because she doesn't have one. Did you hear that? Okay. If you didn't hear that, I said because she doesn't have one. She doesn't have a prostate. She's female. Cystourethropy, usually that's the VCUG. The V in VCUG stands for voiding. So it's the letters stand for voiding cystourethrogram. Okay? And so you fill the bladder up with low concentration contrast until the bladder's full, and then you watch the patient void, typically into a bedpan right on the fluoro table. Okay? If it's a male patient, it could be into a urinal on the fluoro table. Okay? Make sure you're wearing gloves. All right, so the IVU, largely don't do that anymore. It's for the evaluation of abdominal masses, renal cysts, or renal tumors. You can diagnose urolithiasis, that is stones within the ureters, pyelonephritis. Infection of the upper urinary tract can be diagnosed with IVU, hydronephrosis, abnormal retention of urine, especially in the upper urinary system. Okay, that extra urine, because there's a stone blocking passageway to the bladder, the ureter backs up with fluid until there's sufficient back pressure to start swelling the calyxal system. So the calyxal system looks swollen and enlarged in the case of hydronephrosis. And I think we've got a slide coming up that shows you that. Evaluation of trauma, if the patient's been in any kind of accident where there was a laceration into the abdominal cavity. Of course, they want to check the aorta and the vena cava to make sure that those are patent and don't have, slash marks inside of them. But the other thing they want to check is to make sure you have patent ureters too. So I might do a quick IVU for a stab victim in the emergency room. Okay. Preoperative evaluation of function, location, size, and shape of the kidneys and ureters. That's always helpful to the urologist. So the urologist might order an IVU for stone extraction. Okay, they're going to do a retrograde urogram in the OR suite tomorrow, but they want to do an IVU to confirm that the patient does in fact have a kidney stone, and how large is this kidney stone. That determines how they go about getting after it and getting it to pass, or do they have to break it up and then let it pass after it's been broken into tiny bits. Those are the two basic strategies. There is a grabber basket, but a overzealous urologist can actually cause tearing and cuts in the lining of the ureter if they try to basket pull too large of a stone through the ureter. It can also evaluate renal hypertension. The IVU can. But CT can do all of these things too. So, and it does it better. Yeah, here's our hydronephrosis right here. And that hydronephrosis, the black and the white indicator, both point to kidney stones. The black indicator, especially on the patient's left-hand side. You can see that the ureter is dilated superiorly to where it kinks off right there in front of the sacroiliac joint. Okay. The ureter also becomes tortuous. What does that mean? It snakes back and forth. It starts to spiral. It starts to have more curves to it. Okay. So hydronephrosis dilates the ureter, and then also dilates the renal pelvis and the calyx network, the calyx, major and minor calyxes in the kidney. Okay. For an IVU, contraindications. Does the patient have healthy kidneys? Because we're using intravenous injection, antegrade flow. And so the contrast will be passing through the nephrons. We need the patient to be well hydrated, make sure they're not allergic to iodine, and make sure their kidney function is adequate before we inject. And the radiologist makes that determination. We don't even make that determination. We will SBAR the radiologist and then ask them how much contrast they need to inject. And you should understand what the patient's body weight is, because the radiologist will ask you. Normal habitus up to 150 pounds. Your patient up to 150 pounds, you can just use 50 cc's of contrast injected IV for an IVU. Okay. For every additional 50, like this, so the next range above that is 150 to 200 pounds. Okay. I think all the way up to 250 pounds, you're going to add one more bottle, so one more 50 cc's. So you're going to double the dose of contrast for patients that are greater than 150 pounds. Now again, that's radiologist guidance. Larger patients have more capillary networks, so they have more capillary fill. So they actually have more blood volume, and so you need a larger volume of contrast to achieve the correct concentration of contrast in the blood, because larger patients have more blood volume. They have more blood vessels. Okay. High-risk patients will be evaluated with, or can be evaluated with, other modalities. Okay. You can diagnose a kidney stone with a non-contrast CT of the abdomen. All right, risk factors: asthma, previous contrast reaction, circulatory or cardiovascular disease, elevated creatinine level. Of course, we mentioned that was a cause of or that was a sign of dehydration. Sickle cell disease. If the patient has sickle cell, they might introduction of iodine contrast might trigger a flare-up, and then the patient will get hypoxic because of the flare-up of sickle cell anemia. Diabetes mellitus, the patient is going to have compromised kidney function, might have renal hypertension, and will not tolerate being in PO for too long, so schedule them first. And then multiple myeloma is another risk factor for the contrast media induced renal failure. Okay. So watch for those. Okay. Yeah, patients got to empty the bladder and then take off their clothes and put on a gown. Okay. They should be removing all metal from their abdomen. Okay. Including a navel piercing if they have one. Okay. If they refuse, just make a note for the radiologist. Okay. Patients should empty their bladder so that when the contrast does get to the bladder, it's not immediately diluted by non-contrast urine. Okay. The GFR is going to tell us how well the kidneys are functioning. Remember that normal range is 90 to 120 milliliters per minute. Okay. Scout radiograph is also used as comparison for locating stones that are signaled on via hydronephrosis, signaled on contrast images. Okay. You're going to need 30 to 100 milliliters depending upon your patient. Okay. So the asthetic patient, you can actually get away with 30. Normal folks, hyposthetic and aesthetic folks is probably going to be about 50, and then your hyperesthetic folks are going to be 100. Okay. Dosage should be adjusted for infants and children according to age and weight, and your radiologist will have a reference material to calculate that number. Okay. Radiographs are produced at specific time intervals during the IV use. Typically, it was a 0-minute, a 5-minute, a 10-minute, obliques, and a regular film at 15 minutes. And then show the radiologist, and if the radiologist is pleased with the findings, then they will order a 20-minute film with contrast, a 20-minute film post-void, and then maybe bladder, the bladder series, an AP and an AP oblique bladder. Okay, that's the MTMC protocol. Your department protocol could vary from that. Okay. So an AP of the urinary system, yeah, this is a negative urinary system. No stones, no obstruction here. See how the ureters are about the size of a drinking straw on the image? And then also look at the calyxes of the kidney. You can partially see them on the right, but the ones on the left, it's definitive. The calyx, the minor calyxes, see how sharp they look? They look like you can pick your teeth with. Those minor calyxes, that's what you want, okay? If they're blunted, that's a sign of hydronephrosis. So we don't have hydronephrosis in either of those. But notice how the transverse colon basically makes it harder to see that left kidney. It also makes it harder to see the right kidney. So that's a good example of the superimposition of the bowel. Now imagine if there was stool in there, you would struggle to make sense of the edges of the calyxes with all the other artifacts superimposing with a stool-filled colon. Okay. Unless you're doing just nephrograms, you're going to want to do 14x17s for all your images of the urinary system during an IVU. Okay. To do an oblique, okay, so the ureter is superimposed over the transverse process during the AP. Go back and look. It's on the previous slide. And so to remove superimposition with a transverse process and to present the kidney in a true lateral, we're going to oblique the patient 30 degrees to the plane of the IR. So they roll their hip and their shoulder up to about 30 degrees. Notice that's roughly the same as like a sacroiliac joint. So you should see an open sacroiliac joint on side up. And then you see, look at that left ureter. See how it's free from the spine? If you over-rotate and go to 4 to 5 degrees, the vertebral bodies start rolling in front of the ureters, and you haven't reduced superimposition at all. You've actually compounded it. So a 30-degree oblique is all you need to get a nice isolated view and see, well, the right side is the side up, and it's basically the ureter has moved in front of the spine. The left side is side down, and the ureter is pulled away from the spine. So you're going to do a left oblique and then followed up with a right oblique because each ureter shows up on the downside oblique. Okay. Make sure you're centering your image receptor to the intersection of the mid-sagittal plane and the iliac crest. Okay. Check to make sure that the bottom of the image receptor goes past the pubic symphysis, and do your best to include both kidneys in their entirety on this AP oblique image. Okay. Nephrotomograms, it is tomography, which just means moving the X-ray to blur out slices away from the fulcrum. The X-ray tube moves, let's say, from head to feet. It sweeps an arc of 20 degrees. While it's doing that, the bucky tray in the table is moving from foot to head. It's not sweeping an arc, but it's catching the X-ray beam as the X-ray beam goes through its sweep. Okay, It's really neat to watch. A little bit more difficult to learn. You gotta have a good teacher. You gotta have someone who has done this before. The renal parenchyma, the nephrons, and the collecting tube are better visualized on a nephrotomogram. Okay. Typically, but not always, you're going to find your kidneys start at about 7 centimeters, but then they finish at about 9 centimeters. So they're about 2 centimeters, 2.5 centimeters from anterior to posterior. Okay. So when we're looking for adequate contrast, we want to see contrast filling the renal pelvis, the collecting tubes. We want to see them in. We want to see contrast in the nephrons waiting to go to the urinary bladder. We don't want to see any contrast coming in from the venous system because that'll confuse the lines. Okay. Renal cysts or renal hypertension, both of those can be diagnosed with nephrotomograms. Okay. Your nephrostogram, a little different. This is just an overhead plain film, but it involves cannulation of the kidney and the pelvic system, the pelvic calcocyggeal system, in the conveyance of contrast. So you gotta have good contrast flow for this. It's going to go percutaneous through the nephrostomy catheter. So they actually have a catheter placed that tunnels through the back, the skin layer, and enters the kidney, and it even enters a opening or passageway, so that the x-ray techs that are performing the exam with the surgeon can have some idea what's going on. Right, for our retrograde urography, that's a specialized skill. This is the one that's the surgical procedure up in the cysto suite in the OR. Your urologist is going to be running the fluoroscope independently, at least here in the state of Tennessee. Other states, it might vary. They might have licensure requirements and things, or might require radiologic technologists to be present. So it really depends facility to facility, state to state, whether or not you'll see retrograde urography. It involves a cystoscope. So a cystoscope is placed into the urethra and goes into the bladder to visualize the inside of the bladder. That's done by the urologist, and then the cystoscope can introduce a guide wire, and the guide wire can be steered to cannulate each of the ureters, the left and in the trigone. Remember the anatomy slide to the bladder in the beginning of the lecture. So the ureteral entrance point at the back of the bladder, they can slip a wire up in there, and then once they have a wire up there, they can thread a catheter down that wire and then pull the wire back and then inject contrast up the catheter, and they can get a retrograde filling of the ureter without risking shutting down the kidney. Okay, so retrograde urography can be done as a substitute for an IVU if the patient has poor kidney function. Typically, a retrograde urography is the patient has already been diagnosed with kidney stones, and it's part of a procedure to either place a stent or to extract the stone, or similar treatment methods to deal with kidney stones. Thanks. There is a grabber basket that they can employ. There's several. I think there's a fiber optic laser that can be retrograde inserted that can also bust apart kidney stones. There's all sorts of tricks and tools that they can use during retrograde urography, but most often they start out with a contrast injection. But for us here in Tennessee, usually the urologist is doing that themselves, and they don't need the x-ray tech to come to the room. Okay. Injecting retrograde doesn't provide physiologic information. You have no idea whether the kidney is functional or not because you're not pushing the contrast through the nephrons, so you don't know if the kidney is slow or if it's got adequate flow like you would in an IVU. Okay, so that's the downfall of retrograde injection is it doesn't provide you any information about kidney function. Okay. Typically, when we're in retrograde urography, it's to evaluate pathology of the ureter and then also treatment of the pathology of that ureter. Cystogram. A cystogram is done in a fluoroscopy suite. It can be done up in the cystography suite, up in the OR, but typically it's scheduled in a fluoroscopy suite. Vesicoureteral reflux. So you can evaluate if you fill the bladder with contrast and then the bladder refluxes back up into the ureters. The radiologist can actually watch for that on the fluoroscope while it's happening, and they can capture that. Vesicoureteral reflux is one of the risk factors for chronic urinary tract infections. Okay. Neurogenic bladder. Okay, that would involve a bladder where, remember I said it was a pressure signal that triggers the compression and the sensation. Well, you could have that signal is interrupted or not being sent or so on and so forth. And so you can fill the bladder and then have the patient report to you if they feel like they have to pee. And then, when you fill it with 750 milliliters, the patient should, if they have proper neurologic response from the bladder, as that bladder stretches to accommodate the extra fluid, they should get the sensation like they need to go to the bathroom. So you can diagnose the absence of that sensation with a cystogram. Okay, any bladder trauma, rupture, laceration, things of that nature can be evaluated with cystogram, and the iodine contrast is safe in the case of some kind of bladder perforation or laceration and contents leaking into the peritoneal cavity. It's a low-risk procedure. You catheterize the patient, you inject contrast, and you see if it leaks outside of the bladder. There's no risk of stasis or sepsis or any of that. Your own urine is sterile to you, and so it's not going to create an infection or anything of that nature. And the contrast, if it's iodine-based, it'll be reabsorbed from the peritoneal fluid into the lymphatic system. And so you can evaluate bladder trauma with a contrast study under fluoro, get a rapid answer as to whether the bladder is intact or not before you take the patient to surgery. Okay. Lower urinary tract fistula. Now, fistula is when two tubes or ducts or pathways form a transfer opening that is not intended. So the esophagus and the trachea, they're right up next to each other. You can get a hole in the side of the trachea that meets up with a hole in the side of the esophagus, and that's a fistula. The urethra in female patients can get a hole in its posterior side where it creates a fistula to the vagina. Okay. Urethral stricture is the more common pathology in males with hypertrophic prostate that can be evaluated by a cystogram, although typically the go-to exam for that is the doctor's physical exam with their hand, or an ultrasound or a nuclear medicine study can also diagnose hypertrophic prostate. Okay. The posterior urethral valves can be evaluated, and that goes along with ureteral reflux. All right, so our pictures for our cystogram, an axial bladder, you're going to do a straight on bladder, an AP bladder. It's a 10 by 12 of the pelvis, okay? Just the center of the pelvis, the bladder is right in the center of the pelvis. 10 by 12, either lengthwise or crosswise, it doesn't matter. The bladder fits into basically an 8 by 8 square. The bladder fits inside there. So as long as you don't have the patient rotated or obliqued, mid-sagittal plane is centered, and then you center to a point 2 inches superior to the pubic symphysis. For the axial bladder, you're going to put on a tube angle, okay? That tube angle is going to be 10 to 15 degrees cauded. You might recognize this as the same centering and angling for an AP axial coccyx. And it has the same effect. It moves the pubic symphysis down and out of the way. This time the area of interest is the bladder rather than the coccyx. So see how we get a nice unobstructed view of the bladder there. We can actually see the bladder floor, and the pubic symphysis is below the bladder floor. If you do a straight AP with no angle, the bladder is going to be partially superimposed by the pubic symphysis on the inferior side. Okay. Central ray angle depends on lumbar lordosis. So you use less tube angle when they have greater lumbar curvature. Okay. Straight AP of the bladder, you see the slight superimposition of the bladder with the pubic symphysis there. Okay. And again, this looks like 10 by 12 crosswise. Will do just fine. Okay. You can put a letter marker on there. And that's a partially filled bladder. You're usually going to do a bladder projection at the end of your IVUs too, usually at the 20-minute mark. You'll do a full bladder, and then you'll have the patient void after the radiologist says okay, and then you'll do a post-void film. Some of them just want the bladder post-void, some of them want the entire abdomen post-void. Okay, so the PA axial bladder, very similar to the AP axial bladder. It just provides a little bit of compression. Okay, so the patient's going to be laying prone, and we're going to reverse that tube angle so it's 10 to 15 degrees cephalid rather than caudate for the PA bladder. Okay. The PA bladder doesn't add anything diagnostically that the AP axial bladder won't reveal, and so there's a little bit of bladder compression, but it's really radiologist preference. The oblique bladder is an important projection for cystogram because the 40 to 60 degree oblique of the bladder is going to allow you to see the ureteral connections to the bladder on those posterior lateral flanks, if you will, of the bladder. Okay, so you'll do a pair of them. You'll do an RPO and an LPO, 40 to 60 degrees oblique, similar to a Jade view of the pelvis, but again, we're only considering the bladder. You can close your collimation down to about 8 by 8 or 10 by 10 here. Going to align to the pubic arch closer to the midline of the image receptor. Okay. Typically, it's the side elevated is what you're aiming for because that's the ureter that's going to reveal itself as the bladder rolls to the opposite side. Okay, remember the bladder is anterior, the ureters are posterior, and it's a posterior lateral junction that you're trying to reveal. So as you roll the patient to the right, the left posterior lateral junction of the left ureter is going to reveal itself in profile. Okay, center 2 inches above the upper border of the pubic symphysis, 2 inches medial to the upper ASIS, so the elevated ASIS. The elevated ureter is going to be the one that reveals itself and kind of rolls out from behind the bladder for these projections. Okay, there you can see it. I wish they had picked one that had a patent ureter there, but that's the appropriate. And see, it looks like a Judet view, right? That hip is definitely presenting like an oblique Judet view hip. The whole point is to roll the bladder toward the right so we can see the left ureteral junction, but I don't. So I do see the coccyx peeking out right there. So right where you see the coccyx in this radiograph, on that corner of the bladder, that's where you would see the ureter if it was opacified with contrast. They just, for some reason, they picked one that wasn't. So, all right, that is our urinary system. Oh, look, an hour and a half. That wasn't too bad for 47 slides. Okay, so we went through the urinary system anatomy. We described considerations for patient preparation, considerations for contrast media. We talked about the two different concentrations of contrast media, whether you're going antegrade, which is higher concentration, or retrograde, which is typically lower concentration. Type and amount, I talked about for IVUs, you need about 50 cc's, but for cystograms, you need about somewhere around 750 cc's all the way up to 1 liter of contrast, typically for your VCUGs. Okay. We talked about some of the surgical procedures and some of the stuff that's done outside of the X-ray department. We talked about the room that you would need for each of those studies. The IVU you can do in a conventional X-ray room, but a cystogram you're going to need a fluoroscopic suite for, and then a retrograde urogram or a nephrostogram, where there's a catheter inserted percutaneously into the calyx of the kidney. You're going to need a surgical suite and a urologist for those procedures. So make sure you keep those straight. That's one of the quiz questions that I have is for which of the following procedures is actually a surgical procedure requiring a urologist, and the answer is retrograde urogram. I know for a fact that's one of the questions coming up on the test. So make sure you, and I could change that up just because I just told you about it. So make sure you know which equipment is appropriate for which procedure in urography and cystography. You guys have a good Memorial Day weekend, and we'll be talking about this on Tuesday, okay? Talk to you later. Bye.